Are we presenting the opening slide?
Yeah, now it's in full slide.
Good evening, everyone, and a very warm welcome to our exclusive webinar on Bridging Pediatric Essentials and Clinical Practice. I'm Malini Gopalakrishnan, and on behalf of Universities Press, I'm thrilled to have you all join us for this insightful session where we will delve into key pediatric topics with two distinguished experts in the field, Dr. Padmasini and Dr. Ramachandran, authors of Essentials of Pediatrics, which is a contemporary and reader-friendly textbook designed for undergraduates in accordance with the latest CBME curriculum. Just to quickly introduce the speakers for today, Dr. P. Ramachandran is Professor of Eminence at the Department of Pediatrics, Sri Ramachandra Medical College and Research Center, Chennai. His distinguished career spans 40 years, during which time he has provided invaluable knowledge to both undergraduate and postgraduate medical students. Dr. Ramachandran's leadership is further evidenced by his tenure as editor-in-chief of the Indian Journal of Pediatrics and his critical role as a member of the IAP task force dedicated to the implementation and support of the Medical Council of India's competency-based curriculum for pediatrics. Dr. Padmasini is Professor of Pediatrics at Sri Ramachandra Medical College and Research Center, Chennai. She has over 25 years of experience as a teacher and examiner for undergraduates and postgraduates in pediatrics. She has co-authored a textbook on pediatrics, contributed chapters to several books, and published over 70 research articles. She's also a peer reviewer in several national and international medical journals. This session is designed to equip students with valuable insights and practical knowledge in pediatrics. Dr. Ramachandran and Dr. Padmasini's vast experience and contributions to pediatric education make them the perfect guides to help us navigate core concepts, clinical applications, and exam-focused learning. With that, I invite Dr. Padmasini to take over.
Thank you so much, Malini, for those kind words of introduction. Good evening, everybody, and thank you all for joining in. Yeah, so good evening once again. All of us are aware that the undergraduate curriculum has undergone extensive revision in the last 5 years. The new CBME curriculum, as the name suggests, is competency-based and outcome-driven. When we say outcome, what do we mean? For us educators, the outcome that we want is, at the end of this training, the Indian medical graduate should be able to provide primary health care for children in the community. Whereas for a student, the outcome that you want is to be able to pass the subject in your final MBBS exam and to score a high rank in the postgraduate entrance exam. The beauty of this new curriculum is that these two outcomes are in complete alignment. The assessment pattern has also changed to ensure that what is asked in your exams is if you are competent to be a community level primary care provider for children. This webinar is to explain to you how this new book, Essentials of Pediatrics by Professor Ramachandran and me, has bridged this distance between a textbook and clinical practice. We will talk about the unique features of the book and explain how it prepares the student for clinical practice as well as exam preparation. That is, we understand uppermost on your minds. And this we are illustrating through examples from 4 chapters. I will be talking about the highlights of chapter 1 and chapter 27, and Dr. Ramachandran will be talking about the highlights of chapter 23 and 28. Chapter 1 very rightly talks about normal growth and development. What distinguishes a child from an adult is the dynamic nature of growth and development. In fact, I am sure in every medical college, the first class in pediatrics, the professor says, a child is not a miniature adult. Definitely, a child is not a miniature adult, and every MBBS student is expected to know what is normal growth and development in a child. This is a core competency. PE 1.1 is definition of the terminologies growth and development and the factors which affect normal growth and development. PE 1.2 is the patterns of growth in infants, children, and adolescents. And PE 1.4 is normal developmental milestones in all the 4 domains. These are all in the knowledge domain, and you are expected to know how. That means not just knowledge, why. Why is this happening? PE 1.4 is anthropometric measurements, documentation of these measurements in a growth chart, and interpretation. This is a skill, and you are expected to be able to perform anthropometric measurements, plot them on a growth chart, and interpret them. What is different in this textbook is that we have cut through all the voluminous texts. We do not have long paragraphs. We do not have any content which is not relevant to these learning objectives. Growth has been described as an example, I'm telling you. Very simple language. Increase in the physical size due to increase in the size and number of cells. So any student who reads this for the first time, sorry, and who sees this pictorial depiction of this baby increasing in size, understands what is growth. Development, on the other hand, is functional maturation of the body, by which various skills are acquired. Factors affecting growth. This is often asked both in your clinical exam and as a long answer question in your theory exam. Even though the same matter can be explained over a whole page of a textbook, we have depicted all the factors which affect growth in the form of a very simple figure. We have the maternal factors or the prenatal factors, the factors which affect the baby in the intrauterine period. We have the environmental factors which influence growth in the postnatal period. And then we have hereditary factors and hormonal influences. Once you remember these 4 categories, it is easy for you to find out which are the factors and how they fit, which category they fit into. Just salient 5-6 points under each category so that you don't have to remember all the rare causes which you may never see during your lifetime, but you will not miss out on those common causes which you should be aware of when you are examining a child. Simple postnatal factors: nutrition, emotional deprivation, the socioeconomic status of the family, physical activity, infections, illness. Very easy to remember common factors. If you have seen this figure and just looked at it for maybe 60 seconds, you will be able to answer. I would still recommend that you read the text, but basic minimum, you will be able to get pass marks in the long answer question. The second competency is patterns of growth. By patterns of growth, we mean how does the body change with age? Very simple tables. Again, at a glance, you can know what to expect as the baby advances in age. First 3 months, 30 grams per day. 3 to 6 months, 20 grams per day. 6 to 9 months, half a kg per month. 9 to 12 months, again half a kg per month. 1 to 3 years, 2 kgs per year. 4 to 6 years, 2 to 3 kgs per year. Similarly, the increase in length also. If you have a growth chart in which you can plot longitudinally, there is nothing like it. But when you don't have a growth chart and you have to describe the pattern of growth, this is a ready reckoner. What happens during puberty is a growth spurt. There is an exponential increase in the weight and height of the child with the onset of puberty. And how much can you expect? In girls, this is what you expect, 9 centimeters per year. In boys, you expect 10 centimeters per year. Similarly, the overall height gain and weight gain is also given. PE 1.4 is in the skills domain. You are expected to be able to perform these anthropometric measurements. But to perform these anthropometric measurements, you need basic knowledge. After that, you go to the bedside and during your clinical class, you actually do it and learn. Infants are weighed on a digital weighing scale, infant weighing scale. The length of infants is measured on an infantometer. And the key points: keep the head against the headboard. You need 2 people. One will steady the head against the headboard. The other one will extend the knees because infants have a tendency to flex their knees and slide the footboard. After that, the baby is picked up and the reading is taken. The weight of older children, most of us are quite comfortable with the technique. Height of older children, above 2 years of age, standing height. Important points: the heel, the calf, the buttock, the shoulder, the occiput. They should all be in contact with the vertical surface of the stadiometer, and then the headboard is brought down. The height measurement is taken. With this knowledge, you go to the ward, select babies, start taking anthropometric measurements, and you're good. This is an essential part of evaluation of any child who comes to you. Regardless of the system that is involved, you will be asked to take anthropometric measurements and interpret your findings. So all of you would be having a copy of the World Health Organization growth charts. And above 5 years of age, this has been integrated with the Indian Academy of Pediatric growth charts. The link to downloading all these growth charts has been given in the textbook. After you have plotted the age against weight, age against length, or weight against length, you see where the growth point is falling. And depending upon the position of the growth point, you interpret the growth status of the child, also called nutritional status. All points which fall between +2 and -2, normal. If the weight for age is less than -2, it is underweight. -2 to -3 is moderate underweight. Less than -3 is severe underweight. This weight for length depicts acute malnutrition. Again, anything between -2 and +2 is normal. Less than -2 is wasting. Further categorization of wasting: -2 to -3 moderate, and less than -3 is severe. Stunting, same, +2 to -2 is normal, and less than -2 is stunting. -2 to -3 is moderate stunting, and less than -3 is severe stunting. So if you look at this table for a while, and once you learn that chronic malnutrition leads to stunting, acute malnutrition leads to waste, you don't have to keep memorizing what is acute malnutrition, what is stunting, what is chronic malnutrition. You just have to remember the visual of this table. The next important knowledge component in every child is developmental milestones. Developmental milestones are typically described in 4 domains: the gross motor domain, the fine motor domain, the social and language skills, and the social skills and the language skills. To give you an example, this is something which all students dread: how to remember so many milestones. That is why we have depicted all the major milestones in the form of a table. Motor milestones are typically evaluated by pulling the child to sit, and by ventral suspension, putting the child prone, examining the child in the sitting position. And then when the child becomes older, allow the child to stand, walk, and see what other activities the child can do. The major milestone for each age, there is a bold font. What we tell our students is, just take a printout of this and paste it on the mirror in your bathroom. Every morning and evening, we spend 2 minutes in front of the mirror, brushing our teeth. Just go through these milestones. By the end of your pediatric posting, you would have memorized all the important milestones. Now, to understand what do you mean by each one of these, many of us might never have seen infants in our life. We have pictorial depictions of actual babies to make it interesting. This is a baby crawling on his belly. This is a baby creeping on his hands and feet. A baby sitting with support, a baby sitting without support. This makes it interesting for the students, and they're able to apply what they have seen in the table to what the actual baby is doing. To ensure that our learning objectives have been met, at the end of each chapter, we have questions: 1-line answer questions, short answer questions, essay questions, and case-based questions. Very, very common question: define growth, enumerate the factors that affect growth and development. So those students who were listening to me, I'm sure you will be able to write down the answer and get 15 out of 15 marks, or at least 12 out of 15 marks. Because you saw one figure which covered all the important factors which affect growth. And you also learned one simple definition of growth as an increase in the physical size because of an increase in the size of cells or number of cells. When does a child develop social smile? 6 weeks. This is another way of asking the developmental milestones of a 15-year-old. Why this long-winded way of asking? To make it more interesting for the student and to simulate a real-life situation. During every immunization visit, the primary healthcare provider is expected to assess the growth and development of the child and to pick up any deviations from normal and send the child for, I'm sorry, I didn't mean to move it like this. So this is another way of asking what are the developmental milestones of a 15-month-old. So this covers the first chapter on growth and development. We will now move on to chapter 27 on common pediatric emergencies. I have picked 3 important pediatric emergencies. These emergencies you can actually see them in real life. You may be expected to manage them even when you're only an intern in the emergency room. And these may also be asked as questions in your theory exam and in OSCEs. We will just touch upon 3 important emergencies. 27.2, etiopathogenesis, clinical approach and management of cardiorespiratory arrest in children. 27.3 is respiratory distress and 27.5 is shock in children. For causes of for cardiopulmonary arrest, the key difference between a child and an adult, cardiac arrest in adults is usually because of cardiac causes, typically a myocardial infarction. But in children, cardiopulmonary arrest, cardiac arrest is always secondary to respiratory failure. And respiratory failure can be because of either an upper airway obstruction, a lower airway obstruction, a lung parenchymal disease, or disordered control of breathing. Cardiopulmonary arrest can also be because of circulatory failure, hypotension, and shock. And this could be because of metabolic imbalances, hypovolemia, cardiogenic shock, or distributive shock. Very rare is a cardiac cause like an arrhythmia, and the miscellaneous causes include trauma, drowning, toxicology. So if you have understood this basic pathophysiology, it is respiratory failure that leads to cardiac arrest. It is hypotension and circulatory failure that leads to cardiac arrest. You will be able to again remember at least 3-4 causes under each category. And how do these lead to cardiac arrest? Whether it's respiratory failure or hypotensive shock, there is cardiopulmonary arrest, and then there is hypoxia, asphyxia. There's cardiopulmonary failure followed by hypoxia, asphyxia causing cardiac arrest. And in ventricular arrhythmias, there is sudden cardiac arrest. So when you're asked clinical pathway, please remember this figure, very simple figure. You just have to point out how these factors cause cardiopulmonary failure, which if not diagnosed, not detected, not treated, leads to arrest. Management of cardiac arrest, I think all of you will be expected to go through the basic life support course when you come as house surgeons. And many of these questions are asked in your MCQ exams. The first step the first step is to check if the child is unresponsive. And if the child is unresponsive, to shout for help. You can never manage to resuscitate anybody on your own. So you have to shout for help and you have to activate the emergency response team so that they get the defibrillator. And then you check, is the child having breathing? Look for breathing and check the pulse. Don't take more than 10 seconds. If there is no breathing or there is gasping, ineffective breathing, but pulse is felt, provide rescue breathing. 1 breath every 2 to 3 seconds. That means around 20 to 30 breaths per minute. And assess pulse rate. Don't take more than 10 seconds to assess the pulse rate. If the heartbeat is less than 60 beats per minute with poor perfusion, you start chest compressions. If not, if the heart is beating well and perfusion is good, just continue with rescue breathing. And keep ensuring that the heart is continuing to beat well. If there is no breathing, no pulse, then you start performing CPR. If you are the only rescuer, then you will be doing 30 compressions, cardiac compressions, 2 breaths. And if a second rescuer is available, then 15 compressions, 2 breaths. When a defibrillator is available, check if it's a shockable rhythm, shock, resume CPR. If it is a non-shockable rhythm, just continue CPR till the PALS provider takes over. You have to go over this algorithm step by step, assimilate whatever is being shown here to be able to answer all questions in OSCE and in MCQs. Typical questions here would be, when do you start rescue breathing? Which are the shockable rhythms? What is the ratio of compressions to breathing if you're a single rescuer? What is the ratio if there are 2 rescuers? How long should you take for checking for pulse? Just one flow diagram and you will be able to answer some 8 to 10 questions of this type based on basic life support. Next competency is etiology of respiratory distress, a very common pediatric emergency. Very common, so common that this is also asked in almost every second exam as a short answer or a long question. When you think about causes, you group them. Always when you're asked etiology, please remember to categorize. That way you will not miss etiologies. Upper respiratory tract, it could be anaphylaxis, foreign body, trauma, laryngospasm, epiglottitis, croup, mediastinal mass, or a retropharyngeal or peritonsillar abscess. For lower respiratory, it could be asthma, tension pneumothorax, and pneumonia. Cardiac causes of respiratory distress, never forget. Cardiac failure, cardiac tamponade, and central nervous system causes is neuromuscular weakness. Metabolic causes are again rare, diabetic ketoacidosis and toxic ingestions. The third emergency which we will cover in this webinar is management of shock. I think many of you are aware about the different types of shock: hypovolemic shock, cardiogenic shock, septic shock. Regardless of what type of shock it is, what is the management in the first hour? If the perfusion is, I'm wondering how to get rid of this bar. If there is altered mental status and poor perfusion, give oxygen and support ventilation, secure an IV line, and start resuscitation as per PALS guidelines. Do all the necessary investigations. Push fluids in the first hour, 20 ml per kg bolus of isotonic crystalloids. Give 2, 3 or more boluses unless the child develops respiratory distress or hepatomegaly. These are all indicators that the child is fluid overloaded. In addition to that, you have already sent the blood for tests. You correct hypoglycemia, correct hypocalcemia, give the first dose of antibiotics stat. Within 1 hour, golden hour, please give the first dose of antibiotics and consider a vasopressor drip and stress dose of cortisol if the child continues to remain in shock. Establish a second vascular access for infusion of these vasoactive agents. Fluid responsive shock, the child responds to the fluid boluses that you have given. Monitor the child in the ICU. The child is not responding to fluids. You call this non-responsive and you start a vasoactive drug. If there is low blood pressure and the child is warm, start norepinephrine. If there is low blood pressure and the child is vasoconstricted, also called cold shock, give epinephrine. And for normotensive children, you give dopamine. So please follow the algorithm. When to give vasoactive drugs, when to add vasopressin, when to give additional fluids. And I don't think as a primary care provider, you can go beyond this. You can give initial fluid boluses, you can give vasoactive drugs, and you can shift the child as quickly as possible to a pediatric intensive care unit where tertiary level care can be provided. Even if you know up to this, we are good. This is the basic minimum a primary care provider should be able to do. I'm getting stuck so often. I'm not sure where the problem is. Why is my slide not moving? So these are some of the frequently asked questions. Which among the following drugs is used for hypotensive warm shock? We did discuss hypotensive warm shock. There is vasodilation. You use norepinephrine. In basic life support, what is the correct step for an unresponsive child who is not breathing but whose pulse is felt? Pulse is felt, perfusion is adequate. So there is no need for you to give cardiac compressions. Just give rescue breaths. And if the child is not breathing, there is no point in giving oxygen. There has to be some breathing for oxygen to make any difference to the child. So this completes my description of the salient features of essentials of pediatrics. I'll be happy to take questions from you at the end of the second talk by Professor Ramachandran. Thank you all for your patient hearing. I really appreciate that. I will now stop sharing my screen.
Good evening, everyone. So, in continuation with what Professor Padmasini has discussed in two topics, growth and development and pediatric emergencies, I'll be taking up two more topics, which are chapter 23, which is cardiovascular system, and chapter 28, which is respiratory system. The basic funda of this textbook is the competency-based education has come and is here to stay. So it has to be aligned. Whatever is the information we are giving to the undergraduates has to be aligned with this CBME curriculum. We have to aspects which are all going to be, actually you are going to be assessed on the CBME curriculum. So this has to be found in the textbook. What are the things you have to be at your exit exam? They are going to assess you on whatever the clinical skills and the practical knowledge, plus also various systematic analysis and your hands-on experience. That means you have to show certain skills. These are going to be assessed. So this textbook tries to cover giving you the clinical information, that is the knowledge part of it. Then also trying to give you some of the aspects of the clinical examination and certain aspects of your practical skills, both in the textbook and also in the videos and others which are provided along with the textbook. See, what are you going to get in the exam? You are going to get long essays. You are going to get short answer essays, short answer questions. You are going to get MCQs. Then in the clinical examination, you are going to get a long case. You are going to get spotters or short cases. Then you are going to get table viva. These are the aspects which are actually covered in the book. It is designed in such a way that whatever the competencies are given in the CBME curriculum are covered totally. so that the examiner asks these questions, frames a question. These are all available, the information available to you in a very, very comprehensive fashion without too much of elaboration, the points which are really required for you to actually understand and answer. This doesn't mean that the person who wants to learn something more, there are enough information provided in the book which actually explains physiology and the underlying principles of certain interventions. These are also given. So an advanced learner also can get more information out of the book. And there are certain non-course topics which are given, but one may never know. You may get sometimes a short note, something like some program or certain other things. There may be some questions. So which are the important ones are being covered in the textbook. Now coming to the cardiovascular system, what the CBME wants is the students is expected to know clinical presentation. They are given very clear-cut competencies. Management of all these things: congenital heart diseases, rheumatic fever, infective endocarditis, and cardiac failure. So these are all covered in a step-by-step fashion in the book. And among the skills, that is the show how, they are mentioning the cardiac, how do you elicit the cardiac symptoms and document? How do you do a CVS examination? How do you do a blood examination which is relevant to the CVS? Chest X-ray, ECG, echocardiography. Certain aspects of this are covered in the book. For example, the clinical examination is covered in a very detailed fashion. And the chest X-rays, which are usually part of the CVS examination in the table viva, are covered in the book. Can I have the next one? Slide. Yeah. So the textbook, initially it is formatted like this. The learning objectives are clearly mentioned to you. Then what are all the topics which are covered one by one is mentioned in cardiovascular system, which is congenital heart disease, congestive cardiac failure, acute rheumatic fever, infective endocarditis, then clinical examination. And the aspects in the clinical examination, the frequently asked questions in the clinical examination are covered in the self-assessment. And the interventions like cardiac catheterization and cardiac surgery are non-core subjects, but these are also given. And lastly, the key points, which you have to will be very useful for you to remember in every chapter you read. And the self-assessment, short answer questions, and the case scenarios. Because nowadays, there are two ways the examiners ask a question. They say, discuss the pathophysiology or the hemodynamics in ventricular septal defect and clinical features, investigations and management. That is one way of asking. Another way of asking is, a child who's around 2 months old is brought to you with a suck cycle, difficulty in feeding, not gaining adequate weight, and recurrent respiratory problem. So that is another way of asking you about ventricular septal defect. So the book is giving actually the case scenario based discussion for you to understand what are all the things which are covered in the text. This is going to be extremely useful to you for answering both the theory question as well as discussing in the clinical examination. That is how it is formatted. Next, please. Yeah. Now going into the asymptomatic heart diseases. It's been covered, the left to right shunt, like atrial septal defect, ventricular septal defect, patent ductus arteriosus, all the aspects, the clinical aspects, investigations, management, one by one they are given, followed by the other asymptomatic heart disease, which is obstructive lesions like pulmonary stenosis, aortic stenosis, and coarctation of aorta are detailed. Coming to the cyanotic heart disease, the tetralogy of Fallot with its typical Fallot physiology is discussed in detail. Can I have the next slide? And this is the format which has been followed as per the CBME. The classification, pathophysiology, clinical features, management is given for the congenital heart disease. And the illustrative pictures, for example, the times of VAT, the child with a clubbing, a chest X-ray in tetralogy of Fallot, the typical the boot-shaped heart, and the pathophysiology algorithm in cyanotic spell. All these are given. I'll be just showing them in the subsequent slides. Next slide. So this on the left, you can see the type of ventricular septal defect. Because when the examiner is, you're doing well in the clinical presentation, ventricular septal defect, the examiner will be tempted to ask you. He feels that you know something which is just above an average student. So he may ask you, what are the types of ventricular septal defect? So this pictorially gives you a very succinct information about the types of ventricular septal defect. On the right-hand side of yours, you can appreciate the child with a clubbing, pan-digital clubbing. Next slide. You can see on the right-hand side a typical tetralogy fallow chest X-ray. This is very important for you because in the afternoon table viva, these are the X-rays which are going to be kept for you. So recognition of this is going to be extremely helpful. And the one on the left side actually tells you regarding the cyanotic, the mechanism. So this helps you not only in understanding in theory examination writing, it's also in a clinical case, a child has cyanotic heart disease kept for you. Question invariably asks what is a cyanotic spell? How does it, why it occurs? So this helps you both in theory as well as the clinical examination. Next slide. Sometimes, if you say tetralogy fallow, the examiner may ask you, what else can be the differential diagnosis? To make it very easy for you at the level of MBBS, we are given the important differential diagnosis, salient congenital cyanotic heart diseases, how they can be distinguished and how they can be managed. So in one slide, one table, you are actually getting the differential diagnosis for the entire cyanotic heart disease. Next slide. This is a continuation. You are able to see what are all the various cyanotic heart diseases which you will be seeing, which may be asked in the differential diagnosis of a tetralogy fallow. Next slide. Coming to the next aspect, which is acute rheumatic fever. This you may be getting in general medicine also. But in pediatric, mainly we are concentrating on acute rheumatic fever rather than a rheumatic heart disease. Most of the time, a rheumatic heart disease, well established, you'll be seeing more in adults. But a child with a joint pain or an acute problem like fever may come to you during a pediatric examination. So acute rheumatic fever is one of the important competencies, core competencies. So all the aspects about etiopathogenesis, natural history, the whatever is required for CME curriculum are all given in under acute rheumatic fever. Next slide. Now, coming to the questions, the theory questions, how the book, the chapter is aligned with what is required for you for your exam purpose. As I mentioned, instead of directly asking for a ventricular septal defect, a case scenario is given. That is how nowadays most of the questions are put. They want to test your understanding and comprehension rather than asking a direct essay. They just give you a brief case scenario, then ask, which will be very typical. Okay, it will not be very complicated. So you can see the circle is given. You know that it's a left to right shunt. So two such case scenarios are given at the end of the chapter for you to actually think about it. The guideline answers are also given. What you have to actually discuss on these heads, various questions which are posed. Similarly, the case scenario based questions are given to you for cyanotic heart disease and also for infective endocarditis. These, again, not only for the theory examination, for the clinical examination, these are going to fulfill your needs. Cyanotic spell, which is a frequently asked short answer question, is given quite well in the text. Actually, I showed you the pathophysiology. So it's very well described, the cyanotic spell. So this case scenario based theory questions and clinical cases are also given for rheumatic fever. Slide, please. Yeah. Now coming to the clinical examination, the CVS clinical examination, all the salient aspects. Then under the cyanotic heart disease, cardiac failure, all these clinical cases are discussed. And for the table viva, I already mentioned that tetralogy fellow X-ray is shown. Similarly, a child with a cardiomegaly is also shown in the X-ray section. Next slide. So to summarize in cardiovascular system, the basic things, acyanotic heart disease and cyanotic heart disease under congenital heart diseases and rheumatic heart disease are well covered. And also the theory aspects like infective endocarditis, cardiac failure are also well covered. To meet the needs for clinical examination, the case scenario based, which are actually going to be the type of clinical examination cases for you, are given. The self-assessment questions at the end of the section are useful for you, both as a short answer questions. You can answer them based on these questions which are given. So this is about the cardiovascular system, how this chapter is actually aligned and kept for easy reading for the students. Coming to the next chapter, can you go to the next slide? Respiratory system. Similarly, what is asked under the CBME curriculum under the know-how is you have to know about the etiology, pathogenesis, clinical features, management of upper respiratory problems, then lower respiratory problems. Under upper respiratory problems, various aspects, various diseases are given. Next slide. So this is captured in the book in the first opening, where it is mentioned what this chapter aims to cover under the not only the knowledge component and also for the what you have to know, show us the skills like the examination of the ear, nose, and throat, clinical symptoms, how you have to interpret it in upper airway, and also the lower respiratory tract problem, and various X-rays are shown to you. Next. So in our essentials of pediatrics textbook, the upper airway problems are covered, which are asked in the CBME, nasopharyngitis, laryngotonsillitis, acute otitis media, epiglottitis, LTB, acute laryngotracheobronchitis, stridor, foreign body aspiration. Under each of these topics, etiopathogenesis, clinical features, and management are succinctly, very clearly given. Next. Coming to the lower respiratory problems, though in the CBME it is mentioned only as a skill, we actually covered this for the understanding in the theory aspect also in the textbook. We have actually discussed about bronchiolitis, valry, pneumonia, empyema. The reason being, in respiratory system, that these are the two common cases which will be kept for you. A child with wheezing, where you can answer for both valry or bronchiolitis, also bronchial asthma, and also sometimes the child with a lower respiratory infection and pneumonia. So these are both of them are covered. And the respiratory system examination, all the salient aspects are covered. Next slide. The X-ray section, actually, in CBME, they are actually telling you that these X-rays have to be shown. So all these X-rays are covered. Whatever has been asked in the CBME, the pneumonia X-rays are shown. Foreign body aspiration with a one side obstruction showing a hyperinflation, which has been shown. The pleural effusion X-ray is shown. Pneumothorax, collapsed lung. These are very important for you in the afternoon table viva. Some of these X-rays are shown subsequently. Can you go to the next slide? Yeah. So on the right-hand side, you can see the pneumothorax. The good aspect of this thing in this book is, it is not just the X-ray is shown. What actually you have to tell in the X-ray is also given, the information is given to you, so that it makes it very easy for the student to comprehend and actually answer. The second X-ray is shown like right side obstructive emphysema, which usually happens following a foreign body aspiration. So the hyperlucent lung, the increased volume of the lung on the right side, and the bronchovascular markings are present. That differentiates it from the pneumothorax. So that point is brought out very well, this X-ray, and the points which are given under the X-ray. Next slide. The third one, I'm just showing to you the left side at pleural effusion. The salient points are mentioned underneath. like a shift of the mediastinum and total opacity, etc. And the fourth one is a pneumonia, showing you the consolidation and the air bronchogram. And the last one is the collapse. The mediastinal shift to the same side is mentioned in this under the points for the X-ray. Next slide. The frequently asked theory questions which are covered at the end of the chapter are the infant with bronchiolitis, the community-acquired pneumonia. What are all the various aspects which will be asked in the theory exam are given. Short essays, short answer questions like acute pharyngotonsillitis, empyema thoracis is covered. Then case-based long essay, that means the actual case is given. A child with 8-month-old comes to you with acute ear pain. Child is febrile, looks sick. So you have to mention about acute otitis media. So that flow is also mentioned to you. Acute epiglottitis is given, upper airway obstruction. Community-acquired pneumonia is also given as an essay question. The MCQs related to the respiratory system are given at the end of the chapter. Next slide. In clinical examination, the bronchiolitis, asthma, recurrent wheeze, and community-acquired pneumonia are covered in the theory aspect of it. This will make it really very useful for you. It's not only the X-rays are given, actually the chapters are given for the lower airway problem because these are frequently kept cases in the examination. Next. So to summarize, the book is designed to achieve the learning objectives of the competency-based medical education. Plus, it is also preparing you in the format to meet the requirements to get both the theoretical knowledge as well as to show the clinical skills which are required in the exam to come out very successfully in the examination without any hassle, without any real stress for you. So the whole thing is designed in a very student-friendly manner. So we are really hopeful that you will enjoy reading it and really get benefited, and we will really appreciate any feedback from the students on these aspects. Thank you so much for the patient listening.
Thank you, sir and ma'am, for your insightful presentation and sharing your expertise and knowledge with all of us. I'm sure students will greatly benefit from this presentation. I have a few questions, ma'am and sir. Sir, my first question is for you. You've just mentioned that pneumonia is a very important topic for students. How do we differentiate between viral and bacterial pneumonia in a child based on the history, examination, and the investigations that have been conducted?
So the diagnosis of pneumonia first is made as community-acquired pneumonia based on the respiratory rate and the retraction, clinical examination. History-wise, a child who is having some respiratory problem in the form of cough and difficulty in breathing and inability to take feeds. All this will be the clinical clue. Now, to differentiate whether it is a viral or bacterial pneumonia, there may be some easy clues. One is a child who is more sick, a higher degree of fever, is more likely to have a bacterial pneumonia. Nothing is 100% in the medicine, but this is a very important clue. Most of the time, viral pneumonia starts like upper respiratory cold and cough, then it's followed by some difficulty in breathing. And most of the time, the younger children less than 1 year or 2 years, those who get the viral pneumonia, they also get wheezing. So one of the important clinical clues when you auscultate, if you get wheezing in a child who presents to you with acute respiratory problem, you are more likely to be correct. If you say it is a viral problem, most likely a viral lower respiratory infection, something like a bronchiolitis or a viral lower respiratory infection associated with wheeze. On the other hand, you find a child with retractions, and you find the child is look a bit sicker, a higher grade of fever, and on auscultation, you find localized areas. You find some crackles. Very rarely you may get bronchial breathing in the examination because they may not keep such sick children. But if you get a localized area of crackles, and if history-wise, you would have got this child came acutely ill, and the child was given just some oxygen or some IV antibiotics, and now you are examining, you are getting localized findings. You are more likely to be correct if you say a pneumonia. That is a bacterial pneumonia. Okay, so important clue: these more favors a viral pneumonia. Localized findings like crackles in a localized area more in favor of a bacterial pneumonia.
Right, sir. Thank you. Ma'am, I have a question for you. What are the key clinical features that can differentiate the constitutional growth delay from a pathological stot stature?
Very important question, because this is a common dilemma which many of us face even in clinical practice. And of course, when you get a short stature case in your clinical exam, you are expected to give a diagnosis and defend your diagnosis. Constitutional delay in growth and development is a normal variant of growth. There is no underlying medical disorder. Growth and maturation are occurring at a slower pace than in normal individuals. But the growth velocity is normal. Because bone growth and maturation are occurring at a slower pace, the bone age will be less than the chronological age, but the bone age will be equal to the height age. But very important point is, it is a diagnosis of exclusion. That means you make every effort to exclude a pathological cause before you say that this is constitutional delay in growth and development. How to exclude pathological causes? Be aware of the pathological causes. It could be endocrine, growth hormone deficiency, thyroid deficiency. It could be a chronic kidney disease or long-standing malnutrition or a genetic cause like Turner syndrome. And then take a focused history to see if there is a possibility of any of these causes. In constitutional delay in growth and development, the typical history will be that either the father or the mother, depending upon the gender of the child, would have had delayed puberty. Typically, this is a diagnosis we make in boys, and there'll be a history of the father beginning to shave very late in life. And instead of at the age of 13 or 14, he started shaving in his late teens or 20s. Like that, full, complete, focused history, do a targeted physical examination, do laboratory investigations when indicated, rule out pathological causes, then make a diagnosis of constitutional delay in growth and development. Another clue is that in many of these pathological causes, especially endocrine causes, the bone age will be less than the height age. Yeah, vis-a-vis the bone age being equal to the height age in constitutional delay. So these are the salient features.
Okay, thank you, ma'am. I think these points will really be helpful to the students. Sir, my next question will be for you. What clinical signs will help differentiate between a cyanotic and an acyanotic congenital heart disease in a newborn?
I'm sorry, can you repeat the question? It was a...
Right, sir. What clinical signs will help a student differentiate between a cyanotic and an acyanotic heart disease in a newborn?
Generally, most of the times in the newborn period, they may not manifest with a cyanosis, but you can say sometimes, very rarely, a newborn can be born with the cyanosis. Most likely, their respiratory causes at the immediate newborn period. Slightly later, let us say the first week or so, some of the newborn, some of the heart diseases which are causing decreased blood flow to the pulmonary circulation, they can present with a cyanosis. And these children usually are very sick, because not just the cyanosis, they also have, because of a decreased oxygenation. As you are aware, cyanosis indicates that there is a reduced hemoglobin is very much higher. So the tissues are going to be having decreased oxygen. So they are much more sick. Plus also, sometimes they may be associated with decreased circulation. So not only a problem of cyanosis, they may also be acidotic. They may also have decreased blood flow like shock, decreased perfusion. The pulses may be weak. So these are all the usual manifestations when cyanosis is seen in the first week. Acyanotic heart diseases, by and large, because of the basic mechanism, the pulmonary pressure is higher in the newborn period. Majority of the acyanotic heart diseases, which are left to right shunts, like ventricular septal defect or patent ductus arteriosus, usually their manifestation is later when the pulmonary pressure starts coming down. So that's why, though the defect is there, the ventricular septal defect clinical features usually start by around 4 to 6 weeks when they start having this feeding difficulty and success cycle, etc. Sometimes very critical obstruction, like a very severe aortic stenosis or a severe coarctation, they may present in the newborn period with a decreased perfusion to all the tissues. That means the pulses will be weak. They may go into a left-sided heart failure. They may have difficulty in breathing. So right from the newborn period, they will be very sick children. They will not have good pulses. Their BP will be extremely low, and they will not be able to feed or take good breaths. So you start these children in the resuscitation and manage them in ICU. Then you take the X-ray and the echocardiogram, other things, you confirm the diagnosis.
Right, sir. Thank you. Ma'am, I have a question for you as well. The emergency room postings are usually very nervous. The students are very nervous during those postings. So how do they, manage a patient? What is the management protocol of a patient, a child who presents with status epilepticus in the emergency room?
Good, good. Because this is the commonest emergency that you're likely to encounter as a
Right.
primary care provider. It need not even be in the emergency room. You may just be doing an office practice and a child has come with fever. In your waiting room, the child throws a seizure because febrile seizure is the commonest cause of seizure in children below 5 years of age. So it's very important, regardless of whether you are an emergency room physician or a primary care provider in the community, that you know the initial management of a child with seizure. And as I've said before, in this book, we make everything very simple to understand. So I can't resist showing this slide. Just to show the students how easy it will be to remember the steps in the management. The child is having a seizure in your presence. Always think airway, breathing, circulation. See whether the child is breathing, whether the airway is being maintained, or whether the child is choking because of saliva or vomitus. If there is anything obstructing the airway, do suction, clear the airway. You may have to lift up the chin of the child if required. Check if the child is breathing and make sure that the pulses are well felt. Once you have checked this, you start giving oxygen. All this should happen in the first minute. Then insert an IV cannula. You draw blood for these emergency investigations and immediately give a short-acting benzodiazepine. Typically, we use midazolam intravenous, or you can use diazepam or lorazepam. Any short-acting benzodiazepine should be given immediately. And if there is no IV access, then you can give buccal midazolam or rectal diazepam or intranasal midazolam. If the seizure is not aborted, repeat the dose of benzodiazepine once. And if the child continues to have a seizure, you have to give intravenous phenytoin or fosphenytoin. Fosphenytoin can be given as a bolus, but phenytoin IV has to be given very slowly because of the risk of bradyarrhythmias and hypotension. This much care only you can give in the community. As quickly as possible, this child has to be shifted into a pediatric intensive care unit because the subsequent steps of management can cause respiratory depression, and you have to have the facility to support the respiration if respiratory depression occurs. If you have got the child into an ICU, you can start a midazolam infusion. If that is still not working, coma can be induced by using thiopentone or propofol infusion, and finally, you have to consider IV ketamine and topiramide. By this time, your investigation reports will be available and you have to correct whatever abnormalities you have identified. If PICU bed is not available, then you have to give intravenous valproate and keep trying to shift the child to the ICU because you never know when the child is going to develop respiratory depression because of whatever we have done. And you can give IV phenobarbital, but again, try and get a bed in the PICU. Still, you're not getting, you can use IV levetiracetam. This is the stepwise management of a child with status epilepticus. It is good for us to have this cut out and pasted in our clinics so that we don't have to memorize the dose. When there is an emergency, it is not going to be easy to recollect whatever you have read in a textbook a few months ago.
Right, ma'am. Thank you. We have a question from a student. The question says, is persistent cavum vergae alarming in presence of head circumference, abdominal circumference under normal Z score, but ventriculomegaly under normal Z score, other parameters are normal, gestational age being 28 weeks?
Oh, this is a very complex question for a fetal medicine expert. We do not want students to try and get this knowledge. If there is an individual circumstance and there is a personal need to have this answered, it can be done outside this forum. We will focus only on the learning objectives given by the National Medical Council for the Indian medical graduate.
Right, ma'am. I think with this, ma'am, we're done with the questions. Malini, I'll forward it to you.
Thanks, Dr. Asta.
Thank you.
So with that, we conclude today's session, and I'd like very much to extend our heartfelt thanks to Dr. Padmasini and Dr. Ramachandran for taking the time out of their incredibly busy schedules to conduct this session and for sharing their expertise with us all. I'm certain that your guidance has been invaluable to students and will continue to be once the video is up on YouTube. A special thanks to the team at Universities Press for their dedication and effort in putting together this event so seamlessly. And of course, to all our attendees, thank you for being part of this experience in this discussion. And we really hope that you found it interactive and engaging. Thank you so much.
Thank you. Thanks,
Thank you
everyone.
all. Bye.
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 Thank you very much, Dr. Ramachandran and Dr. Padmasini.
Thank you.
Thank you, sir.